I think that as oncology nurses that we need to keep ourselves really educated and up to date with these new therapies, because I honestly feel like we still haven't really seen long-term effects of this treatment.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Lenise Taylor, Oncology Clinical Specialist at ONS. And today our guest is Lisa Parks, nurse practitioner in hepatobiliary surgery at the James Cancer Hospital and Solove Research Institute at the Ohio State University Comprehensive Cancer Center in Columbus, Ohio. We're discussing the basics of cancer symptom management for hepatic complications of cancer therapies, which is part of an ongoing series about cancer symptom management basics that you can find linked in the episode notes. As a reminder, you can earn free NCPD contract hours after listening to this episode and completing the evaluation that is also linked in the episode notes. Thanks for joining us today, Lisa.
My pleasure. Thank you for having me.
Can you start us off with a brief overview of the physiological functions of the liver and then explain how those functions serve a patient with cancer who is receiving anti-cancer treatment?
Absolutely. The liver is a critical organ for numerous physiological processes. For one, it metabolizes macronutrients. It processes these macronutrients to provide energy to help the liver perform its most critical function. The liver stores glucose in the form of glycogen and assembles glucose via the gluconeogenic pathway in response to fasting. The liver also oxidizes lipids and can package excess lipids for secretion and storage in adipose tissue. It metabolizes protein and amino acids for energy and disposal of nitrogenous waste from protein degradation in the form of urea degradation. It also helps blood volume regulation. The liver accounts for 12% of the total blood volume, and half of that volume can be expelled in response to vasoactive agents of extrinsic innervation. It helps with our immune system support. The liver detects, captures, and clears bacteria, viruses, and macronodules. It also is part of the endocrine control of growth signaling pathways. Through hepatokine production, hormone metabolism, synthesis of binding proteins, detoxification, and processing and redistribution of metabolic fuels. And the final function is the breakdown of xenobiotic compounds. It's responsible for metabolizing drugs and drug excretion, and it is responsible for the metabolism of the majority of oncologic agents.
Wow, that's a lot.
It is a lot of functions.
Since we have a better understanding of the healthy liver's functions and processes, can you elaborate a little bit more on how cancer or treatment-related toxicities can alter or impair those?
There is something called chemotherapy-induced liver injury. What the chemotherapy does is it has a direct hepatotoxic effect on the hepatocytes themselves. If you have pre-existing liver disease, such as cirrhosis, it can lead to very severe hepatotoxicity because the function of the liver is already compromised by the damage previously done to it. Alkylating agents like nitrogen mustard, nitrosoureas, alkosulfonates bind to the DNA to prevent replication. If there is damage to the liver, the dose is modified based on the patient's bilirubin, alk phosphate, and aminotransferases. Antimetabolites like 5-FU, capecitabine, fluoxetine, cytarabine, gemcitabine, these agents all interfere with DNA replication and cell division by causing cell death by incorporating themselves into the cell RNA or DNA. And this can lead to non-alcoholic fatty liver disease, nodular hyperplasia, and steatohepatitis. Then mitotic inhibitors like platinum, spindle inhibitors, these drugs cause a marked increase in the LFTs. And often when the LFTs rise, the provider often needs to dose reduce these agents. Anti-tumor antibiotics like bleomycin, mitomycin, anthracyclines like doxorubicin and epirubicin, these drugs can cause veno-occlusive disease, or sometimes referred to as VOD in older literature, and you can see it now referred to as sinusoidal obstructive syndrome, or SOS. And then finally, molecular targeted therapies like monoclonal antibodies and oral kinase inhibitors by blocking pathways involved with tumor progression, angiogenesis, tissue invasion, metastasis, and immune response. And these drugs can lead to viral hepatitis. Then we get into things like radiation-induced liver injury. So before radiation is even offered to patients with underlying liver disease, they should be referred to a hepatologist so that they can utilize medications to optimize their liver function. Radiation-induced liver injury can occur within a few weeks or years after starting treatment. And there is something called a Child-Pugh score, which is used to describe and measure the amount of radiation-induced injury. There are two basic types of radiation-induced injury, classic and non-classic. In the classic type, you will see fatigue, abdominal pain, increased abdominal girth, hepatomegaly, and anacteric ascites. And this usually occurs 1 to 3 months to radiation therapy. You'll see the ALK phos double while the bilirubin and the transaminases remain normal. In non-classic injury, you will see jaundice and a 5-fold increase in the transaminases. Oftentimes, this injury can be minimized by limiting in liver injured patients like cirrhotic patients to 40 gray of radiation, while in other patients that don't have pre-existing liver injury, you can give up to 70 gray of radiation. And treatment for this injury by radiation is basically supportive care. So you're giving diuretics for fluid retention and steroids to reduce hepatic congestion. If you develop any kind of hepatic vein thrombus, anticoagulants and thrombolytics are utilized with this injury.
You talked a little bit about SOS and VOD. Let's talk about some nursing considerations for some of these common hepatic toxicities. So first, can you describe some of the risk factors and signs and symptoms of the development of SOS?
I just want to go a little bit into a little bit more detail about SOS and then go into the risk factors and symptoms and things. When we use these antimetabolites and alkylating agents, you can see an incidence in your patients of 8 to 14%. And with the SOS, the endothelial cells are injured and they become deactivated and cause inflammatory pathways to be initiated by upregulation of adhesive modules. And then cytokines and the chemokines damage these endothelial cells. Heparinase is released by the endothelial cells, and that breaks down our extracellular matrix proteins. And then the endothelial cells become misshapen. They develop intracellular gaps and increase vascular permeability. And this allows fluid, red blood cells, leukocytes, and other debris to leak into the extravascular space and surrounding tissue. And this results in narrowing of sinusoids and slows down blood flow through the vascular lumen. Ultimately, this can lead to embolization and occlusion in the microcirculation. So the risk factors for SOS, you will see this in a pediatric oncology population, usually less than 1 to 2 years of age. And that is due to immature liver metabolism. And also see this with liver damage or in patients who have had prior liver transplantation. The symptoms that we see in SOS can be jaundice, right upper quadrant tenderness, ascites, a very sudden weight gain, hepatomegaly, and liver failure. And some of the nursing assessments that are very imperative in this patient population are, as always, a physical assessment. We're looking at skin color, abdominal exam, looking for girth, right upper quadrant pain, any kind of palpable liver edge, and ascites. These patients need weight monitored on a daily basis. They need their LFTs to be monitored. Nursing is very imperative on instructing these patients on fluid restrictions with their diet because we do limit their fluid intake. Oftentimes, we encourage them to ambulate, and nurses administer electrolytes, which are often in balance with this patient population.
Perfect. Let's move into nodular regenerative hyperplasia. Can you describe some of the signs and symptoms to watch for with this and some of the nursing management strategies?
So, regenerative nodular hyperplasia, sometimes in the literature, you may see this referred to as non-cirrhotic portal hypertension. And what this is a micronodularity of the liver without fibrosis. So, nodules of less than 0.2 centimeters of normal or hyperplastic plates of hepatocytes form next to atrophic compressed trabeculi. And this nodularity is best demonstrated on a reticulin scan. So the pathogenesis of RNH is related to intrahepatic blood flow, which leads to atrophic hypoperfused areas mixed with hyperperfused regenerative areas. Circulatory impairment leads to local ischemia, which then leads to microscopic obliterative portal venopathy with compensatory hyperplasia of hepatocytes. This hepatic damage ultimately leads to portal hypertension without any fibrosis. So the symptoms that you may see in these patients are fatigue, weight loss, abdominal distension, ascites, variceal hemorrhages, and diagnosis for this is made by transjugular liver biopsy with pressure measurements. A liver wedge biopsy may also be used to find the architectural pattern to make the diagnosis. Nursing assessment goes back to that physical assessment, monitoring for fatigue, your abdominal exam for distension, increased girth, and ascites, and monitoring of daily weight, as the treatment for this condition includes diuretics.
Thank you. I think that's a lot. Where would you normally see this appear in patients? What kind of treatments would tie in with it?
You can see this kind of development with any of your chemotherapies. They all have the potential to cause the regenerative nodular hyperplasia.
Thank you. Kind of threw that one to you out of left field. Let's talk a little bit about hepatitis B reactivation and how to monitor for and manage this toxicity.
So hepatitis B viral reactivation is actually diagnosed by the appearance of the Hep B virus DNA in the patient's blood that have the Hep B virus. And you can see the Hep B surface antigens be positive, and you can also see the antibody Hep B virus core antibody be positive. The American Gastrointestinal Association published guidelines on the management of HPV reactivation for patients during immunosuppressive treatment. And they basically do recommend for any patients with a Hep B virus that they receive antiviral prophylaxis to prevent this reactivation from occurring. Also in 2008, the CDC recommended universal HPV screening for all patients before administering chemotherapy. This one you see most commonly in patients who receive chemotherapy for a hematological cancer following hematopoietic stem cell transplantation. And the onset for this hepatitis B reactivation is 8 to 12 weeks, but there have been reported cases up to 2 years after receiving treatment. Again, the hematopoietic stem cell transplant patients represent the highest risk for developing this. At 2 years, 40%, and at 5 years, 70 to 80% risk of redevelopment. And the reason there's such a delay is due to the long delay in the immune reconstitution. Risk factors for this hepatitis B viral reactivation is an age over 50, somebody who has had detectable Hep B virus DNA, graft versus host disease. That's kind of what we get from that.
And then I would imagine that along with the hematopoietic stem cell transplant, with the new advent of CAR T cell therapy and the prolonged immunosuppression with some of those patients as well, that CAR T patients might be at risk as well.
That is correct, yes.
Finally, can you tell us about the risk factors and signs and symptoms for checkpoint inhibitor hepatitis and the nursing management strategies for patients with this condition?
So, checkpoint inhibitor hepatitis, there is a risk for patients who have been treated with our PD-L1 monotherapy of about 2 to 5% risk. And then if you're using checkpoint inhibitors in a combination immunotherapy targeting both the CTLA4 and the PD-1 pathways with combo chemo and immunotherapy, it raises the risk to about 25%. This causes an immune-mediated response as a hepatocellular or cholestatic injury. It's a lymphocytic or granulomatous pattern of hepatocellular and bile duct injury. And presentation in these patients can range from being asymptomatic with a mild elevation of your transaminases to patients experiencing death from liver failure. This normally presents 8 to 12 weeks after you've received an immune checkpoint inhibitor, and patients with a delayed onset that occur after that tend to have milder disease. You can use imaging to confirm this checkpoint inhibitor hepatitis because on imaging, it will show periportal edema, hepatomegaly, and on a CT scan, the T2 view, periportal hyperintensity and attenuated liver parenchyma and enlarged periportal lymph nodes. So there are grades of this hepatitis, and management basically depends on the grade. So in grade 1, we're really just looking and doing close LFT monitoring of these patients. When you get to grade 2, oftentimes corticosteroids can be used and you can resume your checkpoint inhibitor after you get the steroids tapered to about 10 milligrams daily and completely resume the checkpoint inhibitor after your transaminitis resolves. With grade 3 and 4, the checkpoint inhibitor is stopped. These patients may require multiple cycles of corticosteroids for about 8 weeks.
So the checkpoint inhibitors are completely stopped and never restarted?
In the grade 3 and 4, yes.
Thank you. I have just a few more questions for you. What are some common misconceptions about hepatic complications?
One of the most common things that I've encountered in my practice is that there seems to be a thought that once hepatic complications are identified, there is treatment for this. And in these patients, we can't reverse liver injury. Really, what we offer these patients is supportive care. These patients often can decompensate really quickly, and often these patients may require being transferred to the intensive care unit. And it's not because there's any intervention that we're going to do, but I think it's very frustrating for nurses to see these severe liver injuries that are life-threatening and not to be able to do anything about it. So we just do higher monitoring. And again, as I've talked about, sometimes maybe do diuretics and steroids, but really there's not anything we can do to reverse the liver injury.
That's tough.
Yeah, it's very hard on a caring oncology nurse. And I've seen that myself over the years.
What's something that's often not discussed about this topic, but you wish people knew more about?
I think with some of the new CAR T and immunotherapy, I still feel like the effect of these therapies is very subtle and oftentimes doesn't present for years after administration. I think that as oncology nurses that we need to keep ourselves really educated and up to date with these new therapies, because I honestly feel like we still haven't really seen long-term effects of this treatment.
I agree. I think that the small number of people that we treat with these in relation to or in comparison to the number of people that we treat with breast cancer, things can take years before they come up that we're able to identify that it's actually related to this. And at that point in time, the patient is returned home to their primary oncologist. The staff there, the nurses there are not used to seeing some of these side effects either. So we need to have some really good communication open between the centers and the clinical trials people.
I agree. And I also think, especially for an oncology patient that even presents in the emergency room, and I am lucky enough to work at an institution that has an oncology emergency room, I still think that a lot of these patients are not being recognized in the emergency room as that what the patient is presenting with is actually due to the immunotherapy that they have received, because it's not an immediate adverse event. It's something that occurs very delayed from the administration.
That actually leads into my next question is what additional training or education do oncology nurses or other nurses need to better understand these complications?
I just encourage everyone out there to keep attending conferences, be it local conferences or through the Oncology Nursing Society. I can't speak enough to the educational benefits of ONS. I feel like just about every conference that's put on, we are addressing some of the new therapies. We also provide for ONS members our journals, our Clinical Journal of Oncology and Nursing Forum, and to try to keep up to date with that. And I think that's really all on us as oncology nurses, because within the hospital system, at least at my institution, I'm not seeing a lot of journal clubs or in-services being offered to the oncology nurse.
That's a really good point. We can look for our institutions to provide those things for us, but at the end of the day, we're the ones that are providing care for the patients, both at that institution when we go to another one. So we need to better understand what we're caring for.
I was also going to mention that I know ONS has several publications, books, and text on chemotherapy and immunotherapy, as well as radiation oncology. And I do encourage people to utilize those as references also in their daily practice.
We shouldn't be memorizing something. We should always be going to a primary source. Make sure that we know the latest and greatest of things.
Absolutely.
Do you know of any additional resources for patients or providers who want to learn more about hepatic complications?
We did just publish last fall Oncology Basics, and there I did write a chapter on hepatic complications. I had to really do a lot of research as far as trying to bring everything all together. But again, I feel like there are materials out there constantly being published in CJON Nursing Forum that can be more up to date and available to the oncology nurse.
This has been great talking with you and learning a little bit more about this. Do you have any final comments for us?
Well, I just thank you so much for giving me the opportunity. I know when I was working on Oncology Basics, people were very frightened by the liver. I find the liver to be really interesting. So to have this opportunity to share my knowledge with nurses is very exciting for me. And I thank you again for the opportunity.
Thank you so much.
Thank you, Lenise. It was good talking with you.
Good talking with you too.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.